the thyroid function. So again, just like before, we'll start off with just a little review. So the thyroid is one of the body's largest single organs specialized for hormone production. Okay, it actually secretes the two hormones, thyroxine, which is T4, and T3, which is triiodothyronine. The slide that you see here says TSH, and that's a correction should be made. It doesn't actually secrete TSH. TSH is secreted from the pituitary gland and stimulates a secretion from the thyroid gland of the thyroid hormones T3 and T4. T3 is considered the active form of the thyroid hormones, and T4, it's thought that T4 is converted into T3 before it can act physiologically on the patient. Our thyroid hormones are bound to thyroid binding globulins and other plasma proteins. Only the free form of the thyroid hormone actually enters the cell and regulates the pituitary feedback mechanism. 99% of the T3 and T4 are bound to carrier proteins, mostly albumin. You see at the slide, thyroid hormones regulate energy metabolism and growth and development, and that's two of the big functions that they have. The thyroid hormones increase metabolism of all body tissues except the spleen, the retinas, the testes, and the lungs. Everything speeds up or slows down depending on the hyper or hypo secretion. With increases in metabolism, the body's organ consumption and demands are increased. So if I came in and and we talked about increased metabolism, everything would speed up. If we talk to you about the client with a decreased metabolism, that would be slow. Everything about their body systems would be slowed. With increases in metabolism, the tissues will need more oxygen and more blood supply, and in order to do that, the body has to vasodilate. So vasodilation occurs in order to allow more blood to enter the tissues and to supply more oxygen. What we see is what we see here is that blood volume will actually increase and our cardiac output will increase. Ventilations will actually speed up and increase, and all of these are done as a measure to maintain blood flow and oxygen to the tissues. The heart rate and the cardiac contractility increase, and the thing that we see here is that there's very little effect on the blood pressure. And the reason the blood pressure is not affected is because of the vasodilation offsets the changes. So the test of thyroid function, we will talk a little about each one of these. The free T4 test measures the unbound portion of T4 that is free to enter the cells to produce effects. The thyroid stimulating hormone levels are used to differentiate between a primary and a secondary thyroid disorder, and T3, T4, and free T4 are low if it's primary hypothyroidism, while the TSH is elevated. So again, the thyroid hormones would be low in circulation. However, the thyroid stimulating hormone may be elevated. And what we see this in primary hypothyroidism is because the pituitary gland is working, but for some reason there's something wrong with the thyroid gland itself, and so it's not responding to that negative feedback system. The thyroid autoantibodies, which is you'll see as the anti-TPO antibodies, these are useful in diagnosing something called Hashimoto's thyroiditis, which we'll talk about in just a minute. Then you have the radioiodine uptake test. This measures the ability of the gland to remove and concentrate iodine from the blood. So we would use that. It's called a radioiodine uptake test, or a 123I. That's the other way you might see it. So what that is, it tests the body's ability to remove iodine from the blood. Remove and concentrate iodine from the blood. Thyroid scans will help detect nodules and determine functional activity of the gland. Ultrasounds, we use those to differentiate between a cyst and then a solid lesion. A CT and an MRI can be used to demonstrate a tracheal compression or an impingement. And of course, a biopsy is just where they put a needle in and take a piece of the thyroid to test it out to see if it is cancerous or malignant cells. Hypothyroidism can be congenital or it can be acquired. It can be primary, secondary, or tertiary caused. If it's congenital, that means it develops prenatally and it's present at birth. However, as you're going to see in just a second, with congenital, you may not always see the effects of the disorder immediately. Acquired means that it develops later in life because of either a primary or secondary cause or disorder. Again, primary causes, it's much more common in the thyroid. A thyroidectomy would be an example, or an ablation, like if they had radiation to the thyroid gland. That would be examples of primary, meaning that the target gland, the thyroid, was the affected area. A secondary would be like a pituitary problem that caused a impaired or decreased secretion of the thyroid stimulating hormone, and therefore there would be low hormone secretion by the thyroid gland. And then lastly, the tertiary would be an impaired hypothalamus function, and that would cause low thyroid secretion even though the pituitary and the thyroid gland are intact. So again, with congenital hypothyroidism, some of the complications we see would be mental retardation and physical growth impairment. With congenital, there's a lack of the gland, or could be a lack of the gland, and the infant appears normal and functions normally at birth because the hormones supplied by the mother in utero. So initially you may not see the problems, but prolonged jaundice due to hepatic system failing to conjugate the bilirubin may be the first sign that we see. A hoarse cry, an enlarged tongue, the baby is very sluggish or has an enlarged abdomen, possibly even has an umbilical hernia. These are other things that you might see with congenital hypothyroidism. Acquired hypothyroidism is what we're going to focus on. And so in terms of this, I want you to think low metabolism. When the thyroid is not working, when you see the word thyroid, the first thing I want you to think of is metabolism. Hypo means low. Okay? Everything, every body system. If I told you your bowels were low, were slow, then you would get manifestations of constipation. So if you think of all the systems and think low, then you're going to be able to figure out what those signs and symptoms are. The most common cause of acquired hypothyroidism is Hashimoto's thyroiditis, which is an autoimmune disorder that destroys the gland. And autoimmune, remember that the body is destroying itself. Let's see, a major common cause, again, is Hashimoto's thyroiditis. It's a major cause of goiter and hypothyroidism in children and adults, and we see it more common in women, 5-1, as compared to men. Initially, they may only notice a very small goiter, and then signs of hypofunction will occur. So, the manifestations. Slower. I want you to remember that. Hypothyroidism, everything is slower. Some of the big signs and symptoms that you're going to see is weakness and fatigue. They gain weight, even though they have no appetite. They can't handle the cold weather. They're very cold intolerant. Their skin is very dry and rough. Their hair is very coarse and brittle. They have a yellowish skin tone. This is not caused from jaundice or liver failure. This is due to excess carotene in the system because it's not being converted to vitamin A for usage. So they have a yellowish skin color. They also you might see a puffy face and puffy eyes, thinning eyebrows. Their GI motility or mobility is decreased, so they're constipated. And because of this, they may have some abdominal distension and fullness in the abdomen, bradycardia, mental dullness, lethargy, and impaired memory. Okay, sorry about that. Okay. Um, bradycardia and mental dullness, they're just not as clear as they used to be, and they might be very lethargic and show an impaired memory. You can kind of look at the little picture of the guy and kind of get an idea of what that might look like. When diagnosing, when diagnosing hypothyroidism, you would look at the history and physical. You would also do some serum blood work, which you draw some serum T4 levels. You draw some thyroid stimulating hormones. And if you thought or suspected it was Hashimoto's, you would draw the anti-TPO antibody titer. So to confirm a diagnosis, we would see a low thyroid hormone secretion of serum T4, but we would see an elevated level of thyroid stimulating hormone. Again, focusing on the fact that this is primary hypothyroidism and that there is a problem in the thyroid gland, not a problem in the pituitary. So the pituitary is working as it should, and it's putting out the thyroid stimulating hormone, but there is a disconnection there, and there's a problem with the thyroid gland, and it's not responding. A complication that you need to be aware of is called myxedema crisis, or myxedema coma, which is a life-threatening disorder. It's where they develop this hard, non-pitting, this hard type of swelling or edema, and it's caused because water has become trapped in the interstitial spaces, and typically we see this begin around the eyes and the face. So they get this really hard non-pitting edema in the face and the arms, in the face and the eyes and stuff. Moving on to hyperthyroidism. Again, this is going to be the exact opposite. I want you to think high metabolism. So everything speeds up, everything is fast. Tissues are exposed to high levels of circulating thyroid hormone. The most common cause of hyperthyroidism is Graves' disease. And other causes could include adenomas or ingestion of too much thyroid hormone. What we'll see is we'll have increased glucose, fat, and protein use in the hyperthyroid patient, and muscle proteins typically are broken down and used as fuel. And so this happens, and the patient is extremely thin despite the fact that they're eating a lot. So again, here you may see the manifestations of hyperthyroidism are actually related to the increase in oxygen consumption and the use of the metabolic fuels that are associated with the hypermetabolic state. So the patient complains of a lot of nervousness and irritability. Again, I told you they lost a lot of weight even though their appetite is high because they're not processing those fats, carbohydrates, and proteins properly. They're very intolerant to heat. They cannot tolerate the heat at all. They become very restless, sweat a lot, they have cramps, and most of the elderly patients will develop a new arrhythmia called atrial fibrillation. Graves' disease is an autoimmune disorder as well. It's characterized by abnormal stimulation of the thyroid gland by thyroid stimulating hormone that acts through the normal TSH receptors. It's a state of hyperthyroidism, and we see exophthalmos here. I believe you can see that in the picture. It's called bulging eyes. Exophthalmos. EXOPTHALAMOS. That's a word that you're going to need to know because you're going to need to be able to see that. You might also see a goiter or what we call dermopathy, where the skin has problems. You might see eye problems or ophthalmopathy. resulting from cytokine-mediated activation of the fibroblast in the orbital tissue behind the eye. What happens is it causes the eyelids to kind of retract back, and that's what gives the appearance that the eyes are bulging out. And we see Graves' disease more commonly in our women in the 20 to 40-year range. Now, whereas the crisis for the hypothyroidism was known as myxodemus coma, and that was dealt with a lot of swelling and hard tissues and things in the face and whatnot. Hyperthyroidism also produces a crisis called thyroid storm or thyroid toxicosis. All the manifestations of hyperthyroidism that you saw already would be heightened, and it is a life-threatening emergency. Typically, you'll see this caused by an infection or a trauma or a surgery in a patient that already had a pre-existing hyperthyroidism. So they would present with severe tachycardia. Maybe that heart rate is over 140. They would be in heart failure. Their heart just can't keep up. They might be in shock. The temperature can actually get up to 105.3, and that we know that we can't stay there long. And then nausea, vomiting, diarrhea, and restlessness are some other things that you might see in a patient who is in a thyroid storm or a thyrotoxicosis. Everything is exaggerated. And that concludes the thyroid lecture. If you have any questions or comments, I encourage you to email me if you're unclear. The book is an excellent resource, and all of this information came straight from your text. Have a good afternoon.